And thanks everyone for joining us for the final session in the 2021 Revenue Cycle Improvement Bootcamp with BKD. I'm Shannon Norman, Program Specialist with the National Rural Health Resource Center. Today's topic is front-end revenue cycle improvement, focusing on patient registration. If you're able to do so, please connect to your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default. To avoid background noise and feedback, please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you called in on the phone, you can use *2 to unmute your line. You can also communicate via the chat box, which is located on the bottom ribbon in the middle of your screen. If you haven't done so already, please take a moment to type your name and organization into the chat box so we know who's joining us today. In addition to the annual Revenue Cycle Improvement Bootcamp, the Center has compiled revenue cycle improvement resources. A few of these key resources include the Best Practice Concepts and Revenue Cycle Management Guide, and a compilation of tools included in the Rural Hospital Toolkit for transitioning to value-based systems. Following the final session today, the program is offering follow-up one-on-one coaching calls with BKD consultants. So please contact me directly if your staff could use any additional assistance with specific coding and billing questions. And before we get started, we have one pre-polling question. Caleb, would you mind pulling up that poll?
Yeah, thanks, Shannon. The question that we have is patient access is responsible for what % of the claims field on a UB4?
Thanks everyone for participating in those polls. Our speaker today is Adam Yasin, Senior Consultant with BKD's Healthcare Performance Advisory Services Division. Adam focuses on patient access transformation, front-end revenue cycle, and self-pay AR management projects, as well as assisting providers as they undergo process redesign, staffing, or technology changes. He has over 6-year provider and consulting experience working for and with health systems, physician practices, and central business offices in the patient access space. Prior to joining BKD, Adam headed operations for a department of 32 front-end revenue cycle representatives supporting patient registration, financial clearance, and financial counseling functions at a large billion-dollar annual revenue nationally recognized academic medical center. His team averaged greater than $1 million in monthly pre-service and point-of-service patient collections during his leadership. Adam also holds an MHA and MBA from Georgia State University. I'll now turn things over to Adam to get us started. Adam?
Great. Thank you so much, Shannon. And thanks everyone for being here this morning. I hope everyone's got a good start to their day. So today we're going to be talking about front-end revenue cycle improvement, patient registration. So starting off with a quick agenda, we're going to talk about what is patient registration. We're going to go through an overview of patient access pre-arrival functions. Also going to talk about patient registration and pre-arrival performance measurement. And then we'll close out and have some Q&A. Next slide, please. All right, great. Next slide. Okay, so what is patient registration? Patient registration, quite simply, is just to find, all the processes related to the activation of an encounter or an account, including a review of demographic, insurance, and other patient-related information. And what this visual is really showing you is just really the sequence of steps that occurs prior to a patient's arrival for their encounter, beginning at order entry, moving clockwise to insurance verification, authorizations management, the scheduling of that appointment, the pre-registration of that appointment, medical necessity screening if applicable, of course, the arrival of the patient, registration check-in, and then ultimately a patient liability collection. And over the next several slides, we're going to go into each one of these pre-arrival functions and talk about best practices. So let's start with order entry. Next slide, please. Oh, actually, let's talk a little bit more about why patient registration is important. So what this visual really hopes to accomplish is underscoring how data cumulatively is acquired for claim billing. And as you see, reading left to right at the bottom of the screen, we start with our patient access operation in the scheduling and pre-reg financial clearance space and move further down the revenue cycle into charge capture and entry, coding, claims processing, and then all the way out the door for claim submission. Ultimately, as the polling question had alluded to, patient access has a big role in making sure that we get a good, clean claim submission. And as we validate the integrity of our data through our various touch points with our patients, it really matters downstream for various functions. So let's go on to the next slide. And this really just underscores it. So the UB04 claim form used in billing for hospitals and other institutional providers is made up of 81 different data fields. These data fields are called form locators. Patient access is accountable for obtaining greater than 60% of those fields. And so we have some examples listed here, patient name, age, sex, date of birth, insured name. These are just a handful of some of the demographic items that are captured by patient access. Of course, insurance eligibility, if applicable, any authorizations requirements, all of this information is gathered by the patient access function, for these claim submissions. So we've set the stage for the role patient access plays. Now let's get into those best practices, beginning with our pre-arrival functions order entry. Next slide, please. Okay, order entry. So, what we want to do is really communicate expectations of timely provider order entry. And this is the foundation. Timely provider order entry really triggers the start of the patient access process. As patients come into your ambulatory clinics and receive consults, or physicians not affiliated with your system are ordering services in your hospital. Ultimately, that's messaged to the hospital through an order. Now, there's components of the order that we need to do other downstream processes in patient access. So we want to establish policy that requires a physician signature on an order. CMS requires a variety of components of the order, but we find with many of the clients that we work with that one of the toughest things to do is to get a physician signature on the order. Oftentimes, it has to deal with the provider's schedule. They want to complete that at the end of their shift or at the end of the day. But really, best practice for order entry to make sure that we take our first best foot forward in financial clearance. We really need that signature, and that's going to be important for getting that claim reimbursed. The third item here on order entry is really a reference to priority. So you want to implement provider options for priority indicators on all of your orders. So, quite simply, you need to be able to communicate to the hospital that the order that I'm sending over is either routine or it is stat or urgent. And the reason why is because, patient access really needs to treat both of these priorities in very different ways. Ultimately, we want to be able to hardwire dedicated processes that can expedite scheduling when a patient's order is indeed stat and urgent, with an emphasis still on obtaining, that authorization requirement if it's applicable. If it's routine, we structure a different set of processes that is really methodical, that's thinking through the financial clearance of this patient for the service, and these indicators are going to help your hospital-based schedules understand how to react. Lastly, order templates. So you want to develop order templates that accommodate a description of the service and the corresponding CPT code. So we often see with a lot of clients that we work with that oftentimes the orders will come across as a description, MRI of the hip. But for downstream pre-registration function and really robust patient estimation, we really need to know the CPT codes that are going to be performed. And oftentimes this is achievable. The order templates can accomplish that by making sure that you have a corresponding CPT code for every description in your order set. So next slide, we'll talk about insurance verification. Insurance verification best practices, you want to implement a check of insurance eligibility, benefits verification, and coordination of benefits each time an appointment is scheduled and each time a patient arrives to check in for service. And that's without exception. And I really want to emphasize on the benefits verification. We often take the step to send that 271 response to the payer and figure out if that patient is eligible. But what we really need to do is, interpret the response from the payer, read into the details of the benefit, and make sure that this patient is financially cleared so that as patient access professionals, we can act accordingly to clearing that patient. In addition, expectation communication is going to be really important to staff, that they should leverage all available options to verify insurance. So electronic eligibility software is common for most hospitals and health systems, but when those aggregation sites are down or when there are issues, oftentimes we just kind of throw our hands up and say, come on in. So we want to be a little bit more diligent. Let's go to the payer websites. Let's reach out telephonically if necessary. Ultimately, you are providing good patient satisfaction by taking these efforts, making sure that when the patient arrives to your system, that you're being good stewards of assigning their health insurance benefits on their behalf. And so part of that is making sure that we do everything we can to validate any health insurance if available. Item 3 here is really referring to batch launch eligibility. And what that is just an electronic file that many health systems will send of scheduled encounters in the future to payers, usually done in a night job overnight. And this is really just an en masse way of verifying insurance. So each one of those encounters that you have scheduled, those patients have insurance plans that are registered on your patient accounting systems. And this is one technique that's quite effective to, like I said, create an en masse launch of these insurance plans and potentially work an exception-based work list for any plans that do kick out as ineligible, sort of narrowing your to-do list for the big day for the patient's arrival. And then finally, we want to publish internal guides with screenshots of accepted insurance cards. Verifying insurance is really half the battle. We also want to catalog that insurance appropriately in our patient accounting system. Ultimately, we recommend developing a kind of a robust, a living document guide where screenshots of these insurance cards are collated, and as patients in your community present, you get a clearer picture of your payer mix and a better reaction time on getting those patients cataloged in your system appropriately. And that's going to have downstream benefits for on-time claim submission. So we'll move on to authorizations management, our next slide. So authorizations management, this is a big one. I mean, this is really where we're seeing a lot of growth in terms of payer pushback with respect to getting your patients financially cleared for their big day. Item number 1 recommends, developing an authorization mapping dictionary that crosswalks insurance plans, CPT codes, and authorization requirements. This is something, that I think a lot of organizations do try, to maintain, but really want to elevate this type of document with a lot of communication to your denials team, understanding patterns in your denials data, which may indicate changes in authorization requirements. So having a master dictionary that collates all that information is going to be key for being able to react timely to those authorization requirements. And the second item is, you want to establish policy around authorizations management that is specific, that details exception scenarios for scheduling without an authorization. So I referenced earlier that you want to be able to indicate a priority status on your orders, and this is one place in the revenue cycle where that comes into play at the authorizations management stage. So the policy should detail that if you have a stat and urgent encounter that you without delay get that appointment booked, but certain expectations on the ordering provider should be incorporated to have that team reach out to a payer and receive or obtain the authorization if applicable, despite the fact that it's stat and urgent. You want to try to complete that by the end of the day of the date of service. So that's going to be a short timeline usually in those urgent scenarios. And then item 3, account checks, implementing account checks on encounters for missing authorizations for denial high-risk areas such as inpatient admissions and outpatient surgery. What this simply is leveraging your patient accounting software to hold any discharged patients who have a missing authorization. Usually this is driven by a dictionary that you can populate and essentially instruct your patient accounting system to not submit the claim if that field is missing. This gives an opportunity for your authorization staff to do a manual review, check for any add-on procedures in the case of surgical encounters that have occurred in the hospital. So this is a really effective approach. Oftentimes, you get that claim out the door, you get it denied. It's a much harder conversation to have to try to get a retroactive authorization for that encounter. So account checks stop those discharge encounters and give us a pause to make sure that auth is there before we send the claim out. So highly recommended for your high risk denial areas in the hospital, so inpatient admissions and outpatient surgery. And then the final item, it really piggybacks there. Trending and analyzing your missing and or invalid authorization denials will really inform all of this process. So whether it's the policy that you draft, the mapping dictionary that you construct, the account checks that you leverage, this is really informed by the data. So we want to make sure that, as an example, if a payer plan expands authorization requirement across sites of service, which we see them doing today, that we're agile enough to be able to incorporate that in our process and respond accordingly. So on to appointment scheduling, our next item in pre-arrival. So appointment scheduling best practices, we want to, always implement minimum scheduling requirements for those routine priority hospital encounters. And, three key elements. There is going to be a signed provider order on file, insurance verification or a self-pay deposit collected, and any plan authorization requirements having been met. So that's for your routine priority. Every time we want to have that pause and go through this sort of algorithmically, thinking about, do we have all the items that we need to financially clear this case or this procedure or this image? So item 2, establishing policy. Again, emphasizing here, establishing policy allowing urgent priority hospital outpatient encounters to be scheduled without delay. Both is the right thing to do. It supports our mission here to get patients in without delay when they need us. But I think by being really specific and articulating a policy in this area, that just helps make sure that hospital-based schedulers and ordering providers are on the same page, so that we make sure that we do what we can to protect the financial risk and margin of the facility and the provider for any encounter rendered on the hospital campus. Additionally, in the realm of policies, we want to establish policies that requires that insurance eligibility verification, that collection of a self-pay deposit or financial assistance approval, if applicable, in order to be scheduled. So we just want to move through, each of the motions, making sure that we understand, how this patient is presenting to our organization in terms of their financial clearance and their financial coverage for their healthcare services. So that's going to be another item there. Finally here, again, trend and monitoring is really a theme throughout patient access, and in the space of appointment scheduling. Understanding your appointment realization is going to be key. It simply is just calculated by dividing the number of appointments rendered over the appointments scheduled over a given period. So that gives you an opportunity to understand how effective you are at delivering your care and dealing with cancellations and other rescheduling that has to occur related to an inability to get the case cleared. So it's a key metric and highly recommended for your hospital outpatient schedulers. And so we move to pre-registration on our next slide. And with pre-registration, it's simply the validation of demographic and financial information for a patient's encounter ahead of that encounter. So at least one day before the date of service. It's recommended between 3 to 5 days is really the sweet spot to be picking up encounters and pre-registering them. And that's just going to allow you to make sure that you validate all the information that you need. That's partially the 60% of claim form locators we talked about. We want to make sure that information is correct and give the organization enough of a time to adjust if we find out different information, such as a change in insurance coverage, maybe your self-pay, or maybe we need to connect you with a counselor. So the first item here is establish pre-registration productivity tracking. and monitor that performance. So, best practice goal for pre-registration productivity is 94%. So 94% of your scheduled hospital outpatient encounters should get touched about 3 to 5 days from the date of service, and a process of pre-registration should be undertaken. Item 2, you want to implement robust staff quality audits and review patient accounts. We'll look at a sample quality audit at the back end of this presentation, but this is just to ensure accuracy and completeness of the pre-registration process. It's going to be really important to, incorporate a cadence to those quality audits to allow for coaching. We're asking a lot of our patient access staff, and really the function has evolved tremendously over the years. And so, with all the complexity there at the point of service, pre-service, want to make sure that we're giving that timely, constructive feedback through those quality audits. Item 3, price estimation, real hot topic, as we all know. So we want to develop price estimates for all hospital outpatient services and ask for a minimum deposit for both insured and uninsured patients. Like the quality audits, we'll address estimates a little bit later in the presentation, but pre-registration is really where you want to, insert the price estimation tool. Obviously, from a customer service standpoint, it's ideal to be able to respond on demand to any kind of patient estimate requests. But as a matter of process, integrating your estimation function within pre-registration allows for, it allows for the patient to have some information heads up on their patient financial liability, and greatly increases the chances that you either get that collection during the pre-registration phone call or at the time of service when the patient arrives. And then finally, you want to position your pre-registration staff to function as a coordinated patient access safety net. So that's just to ensure that all scheduled patients are financially cleared for their upcoming service. And there's a few examples there, as you can see on your screen. That's a check to see if an authorization is on file. If that patient is uninsured and doesn't qualify for financial assistance, in other words, self-pay, that we have a pre-care deposit obtained. If they are insured and we've calculated an estimate for their deductible and coinsurance for that hospital encounter, that we collect that deposit as well, and any financial assistance that may be applicable. In addition to all of the demographic fields that are going to be necessary for making sure that we get that claim out the door without any edits in our patient accounting system or initial denials, quick denials from our payers for missing items. So I want to position them as a safety net. Let's move on to medical necessity screening. So best practices for medical necessity screening is you want to develop a financial clearance process that ensures a check of medical necessity prior to service. You're going to want to have dedicated efforts to ensure that they are obtained for affiliated and non-affiliated providers. What we see with a lot of our clients is that we often forget that non-affiliated providers render services in our hospitals, and each time they do so, they present financial risks to the hospital for the facility charges that occur for those encounters. And so, really thinking big picture about medical necessity screening. You can carry that over even to a determination of any authorizations that are required is going to be beneficial for health systems to consider, regardless of who that provider is. But we do often see that there tends to be strong alignment with the affiliated providers of a system, and for those non-affiliated providers, those things do tend to get past us and result in denials for missing authorizations or for a lack of a medical necessity screening that didn't take place. So something to think about. The second item there, of course, you want to leverage your UR and case management to assist in ensuring those medical necessity screenings are conducted for patients in the inpatient setting, pretty standard for their process. Lastly, want to implement rescheduling protocols and assign accountability for appeals for services that are initially denied by the payer due to medical necessity. This is a tough one, because it really requires buy-in from your providers and not really just an administrative take on this. So I think that it is important for a lot of policy and process to really envelope each and every one of these pre-arrival functions. And this is a perfect example of where you're going to want that buy-in and communication from your provider so that we know how to react and quickly when we find out that an event may be denied for medical necessity, and maybe we can pivot for a collection of a deposit to kind of mitigate our financial risk to move forward with the case. Okay, so we'll go on to registration and check-in. Thank you. So we're now at arrival, and we've come a long way, right? We've had our order generated. We've gone through this sort of scrubbing process by our patient access professionals, and now we're here for the big day. So a few best practices to keep in mind. You want to develop comprehensive registration processes for all hospital encounters. So we really want to think enterprise-wide here with all of our outpatient encounters, inpatient encounters, and often overlooked our emergency services as well. Developing these registration processes really means having a standard operating procedure, having a minimum set of expectations of patient access staff for how they engage with these patients. Certainly anything to deal with the demographic and financial information we've reinforced in this presentation. But above that, any collection of consents, any collection of forms at that point in time. So having robust process will be helpful as staff inevitably turns over and you need to be able to pick the ball up from where you were before. Item 2 here, you want to direct registration staff to follow up on those price estimates previously created. And if no collection was made, to ask for a minimum deposit, both for the insured and uninsured patients. So, oftentimes, I think many of you out there could probably agree that, getting a phone call, especially from a number that you don't have saved in your phone, is often daunting, right? A lot of folks don't pick up the phone, but for those that do, it's even harder to provide your credit card information, particularly for our older population. Generationally, we've seen some pushback on engaging with our patient access staff over the phone. But what that pre-registration conversation does is it allows for registration to follow up on any gaps that need to be closed, maybe a collection that was promised to be paid, but not at the time of the pre-registration call. And you all know the story, right? So you're calling me 3 to 5 days out. Well, I got to talk to my spouse. I have to transfer from savings to checking. We've all been there. So having that robust process and pre-registration really tips the patient of your expectations and allows a smoother, a clearer conversation to occur at the point of service where the patient doesn't feel surprised. And that's very important for their satisfaction. So want to be following up on those price estimates simply. Item 3, again, in the realm of quality audits, you got to have an implemented staff quality audit here for your patient accounts. You want to ensure that accuracy and completeness. This is going to be similar, if not identical, to the quality audit that you leverage with your pre-registration staff. We'll talk a little bit more about elements of a quality audit in just a moment, but we'll keep going here and talk about a financial clearance review at check-in. So final item here, establish a financial clearance review at check-in. And again, this is just reinforcing that sort of methodical, almost robotic reaction to each and every one of these steps where we go down a checklist of items that just simply have to be completed in order for you to be arrived for your service. If we do this right and we do this kind of orchestrated, the patient doesn't realize it and thinks that this is part of the process, and we do it over and over and over again, and it's part of their expectation. It's when we break the process up or we do it inconsistently, or some staff do it correct and some staff don't, that the patient gets upset, and you start to hear that pushback whenever you're asking for things of them, such as, I need a new address from you for the patient statement, or can you provide us an email so we can give you timely notification of your liability, or so on or so forth. So consistency is key. Let's talk a little bit more about patient liability. Next slide. The next 2 slides are going to be on the topic of patient liability, and I kind of want to back into this, starting with those patients who present who provide us an opportunity to collect. In other words, they don't qualify for financial assistance. So item 1, strong recommendation to phase in pre-care deposit requirements with price estimates to support collection asks. So we often see in the ambulatory setting that when we ask our patients for their copay, they're really familiar with that. That's something that they understand. Oftentimes, we don't have to really provide evidence of a copay requirement by turning around our computer screen. They accept it. It's really commonplace. But when we get into the hospital, it gets a little bit trickier. Certainly, the numbers rise in terms of liability. We've seen this advent of high deductible health plans, and this is really underscored in the hospital setting where a deductible and coinsurance is triggered for services rendered. And so, beginning with a narrow set, and I say here a narrow set of outpatient services, and assigning a pre-care deposit to those outpatient services is really the best way to go. So the way we see organizations take this on is they'll take advanced imaging and commit to providing 100% of estimates for all advanced imaging rendered at the hospital, and ensure that there's a collection ask, and weaving in your process, a point of notification for that patient. For many, it's pre-registration. That's the first time that we talk to the patient about this expectation. But you could hardwire a process where the ordering provider at the consult, the provider that said to go get that MRI at the hospital, actually, lets that patient know that there's going to be a payment requirement there. We can tee up this conversation to our desire, as long as we're, kind of organizing sort of the chorus here. And that's recommended. Other areas that we've seen, hospitals really focus in on that 100% blanketed estimates is endoscopies and diagnostic colonoscopy. So what this will allow you to do is really just dive in to an area where the industry has generally accepted that these services are elective in nature. Certainly advanced imaging could be urgent and you need to have it, and that would be different. But this is in the realm of shoppable services, and this is where we really recommend organizations to focus their pre-care deposit requirements and the assignments of those dollar expectations by service. Item 2, you want to ensure all registration points of the hospital, and that's inclusive of, your surgery centers, your imaging centers, your sleep labs, among others, all have the proper system access and training to facilitate point of service collections. I'm not sure I've been at an organization where I haven't seen at least a pocket or an island of the hospital or health system where patient access doesn't actually have oversight to the operations that happen there with respect to financial clearance, patient collection. So, having that sort of enterprise-wide view and understanding that, there are parts of the hospital that, you often see this with oncology services or sleep labs where, they may be doing their own thing. This is a great opportunity for your patient access leadership to sort of go on a road show and make sure that as an organization, we sort of have a shared service mentality at how we approach patient access. So all of those registration points need to be explored and make sure that we have, sort of a standard approach there for that intake. Item 3, emphasis here on conservative. You want to develop a conservative and reasonable flat fee surgery deposit and require patients to pay those. And those are preconditions for elective services. This item here is really for surgeries. With most price estimation software, there typically is automation that's available for those organizations that pursue it. It's highly recommended because, as we know, with advanced imaging, endoscopies, diagnostic colonoscopies, the encounters can be numerous. If you throw in surgeries into that pot, you're now dealing with an untenable amount of procedures to quote. So for surgeries, taking a step back, I think the best recommendation here is, instead of to go front forward trying to create an estimate for every surgery encounter that's scheduled, create a flat conservative deposit of $250, $500, and have that sort of as a down payment, a deposit. Really, it's not a fee; it's a deposit towards their expected liability. That confirms the case, which is always positive for OR time that's competitive. That allows for the patient to sort of get involved in the cost of their care early on, and also helps start a conversation about paying for care early on. And we've seen success in our downstream kind of billing process to those patients if we can have them pay something prior to the rendering of care. For surgery, that's one approach that we've seen be quite successful. And then finally, want to trend and monitor patient cash collection efforts at the point of service and through the pre-registration process to identify areas of improvement. So it's really neat when you're able to get sort of a holistic view of how point of service collections are doing across your organization, when you're able to see those dollars and cents by department or by visit location. A little bit later in the presentation, we'll take a look at some sample dashboards and how one organization has approached it. But ultimately, as a patient access leadership team, it's going to give you the ability to understand where you have opportunities, where we can praise our staff for where they're doing it well, and identify gaps. So highly recommended to trend and monitor, of course, that patient cash collection effort. Next slide is along the lines of patient liability with a financial counseling tilt. So we're going to go through a few best practices to think about for our patients who may need financial counseling services. So you obviously want to, and of course this is an ACA mandate, but you want to publish clearly and conspicuously your organization's financial assistance policy and implement process that connects patients to financial counselors during both pre-registration and registration check-in. I think through experience, patient liability professionals understand that patients are not very forthcoming about their ability to pay. Through a pre-registration process, it sort of forces a conversation. And so for the hospital setting, that's mutually beneficial. The organization is presented with high financial risk for taking on the case. And of course, the patient may or may not be able to pay for it. So by having, a kind of dedicated pre-registration function, we can catch this ahead of time and make sure that we're connecting those patients to our financial assistance programs where applicable. Without that pre-registration process, we get to the date of service and we have an awkward conversation potentially, especially if the organization is going to ask for a deposit and sort of kind of stand their ground on that. Item 2, you want to be able to establish self-pay uninsured discounts and direct staff to offer them to uninsured patients who do not qualify for financial assistance. So we have a lot of patients, right, in our communities who might be uninsured, but a little too over-resourced for our financial assistance policies. These patients really deserve and need a self-pay uninsured discount comparable with your managed care contracts that allow those patients to access care. We want to make sure, especially in the realm of the new world of price transparency, you don't want to be the organization that can only offer the gross charge to the patient and then bill them for it without a discount. We've seen that. It's really tough. I think that escalates your bad debt as a percent of net revenue and your bad debt placements overall. So having a self-pay uninsured discount, that's patients with the profile of not having insurance, but not qualifying from financial assistance is going to be key offering for your patients to make that cost reasonable. And then finally, this is something that we've seen. It's kind of a really, really targeted kind of financial counseling treatment, but very effective. And for many organizations, this may be something to consider. But the implementation of a COBRA Premium Assistance Program. So that's essentially what it sounds like. It's the hospital or health system assisting patients with their COBRA premiums. Now, that's not always advisable, but for patients with extended care plans, such as in oncology and in infusion services, where they're our patient, but they're obviously going through sort of an extended illness. And what we see time and time again in these high cost, high dollar areas, really significant financial impact to the health system, is patients, as they, kind of deteriorate and wane, going to work is harder. And so many of them are separated from their work. They've qualified for COBRA and at this point are having a hard time making ends meet. So just an idea there. We've also seen that in the inpatient setting for certain patients as well. You have to be clear about eligibility for something like this. It's something you want to wrap a project around, but just again, yet, another way to kind of put $500 down for a COBRA premium to potentially avert a $20,000 infusion denial. So small cost. Okay, let's go on to the next slide. Great. So we're now reaching the back end of the section. We're going to talk about patient access performance measurement for a little bit. I'll be sure to leave some time for any questions that come up. So staff quality audit scorecards. Let's talk about some key features of a quality audit scorecard. To the right hand of your screen, there's a summary table there. You want standardized questions for all patient accounts reviewed. And in the example to the left, there are 3 domains: registration accuracy, insurance and benefit verification, and collection action. And as you can see here in this sample quality audit scorecard, we've been very deliberate about the criteria that has to be met in order for a staff member to get a check or a point for that item on this scorecard. So having standard questions allows a number of things. Certainly, it's an equitable approach at rating your staff. It provides you the opportunity to see at a department level, for example, we have MSPQ on this scorecard. How is the team reacting to MSPQ? Are we, as the criteria states, is MSPQ attempted on all Medicare patients? Is it not attempted on non-Medicare patients? Has it been completed in full? Emphasis on no missing answers to required questions. So that's sort of the method that we recommend. And as patient access leaders, we can use these scorecards to really understand opportunities amongst our team and let this be a living, breathing document. We talk about that here a little bit more. So item 2, minimum number of patient accounts should be reviewed each audit period. You might get into a patient account and see that, staff member Adam, missed the patient and subscriber relationship. We want to make sure that we're looking at anywhere from 5 to 7 to maybe even 10 accounts over any given period, whether it be weekly, biweekly, monthly, so that we can understand if that's really an outlier or a pattern that might present a coaching opportunity. And then finally, want to identify department level trends and scan for new opportunities to include in audit. So we've seen organizations use these staff quality audit scorecards to do a lot of innovative things. Maybe, we've seen an organization who really wanted to drive patients into their patient portal. And so had a big initiative on getting as many patients in the patient portal as possible. And so the patient access leader at that organization included, capturing of an email address or registration in the portal as part of their quality audit, and then drove that initiative. So stay tight with no more than 10 items that you're really looking for. Key in on those, do that for a period of time, and then recycle out new initiatives in your scorecard. Some are going to remain, some are going to change as times change and requirements change. So just a neat tool there that you can leverage on a cadence with your staff. Next slide, please. We're going to talk now about KPIs, so key performance indicators. So over the next 3 slides, we're going to introduce 3 key performance indicators that are just a collection, and I really mean a scoop of the possible metrics that a patient access leader can keep their eye on to measure the health of their operation. So the first one is going to be the insurance verification rate. What it is measuring is the effectiveness of the organization at verifying insurance eligibility, quite simply, right? How it's calculated, you're taking the total scheduled encounters where you have verified that insurance, and you're dividing it by the total scheduled encounters. And over to the right, we're incorporating here on this slide, National Association of Healthcare Access Management access keys benchmarks for good, better, and best organizations. And as you can see here, the best organizations are verifying 98% of their encounters. So that's quite high. We tend to see, organizations more between the 80 and 90% range. And again, if you're not calculating this metric today, you need to have your eye on it. It's a indicator that has to be part of your portfolio of metrics as a patient access leader. The next one as well, we'll go to the next slide, pre-registration rate. So again, just another metric that I can't emphasize enough is going to be key to be on your patient access dashboards and to the right-hand side of your patient access leadership. What it measures, how effective the organization is at pre-registering scheduled encounters. So this is calculated simply by taking the total scheduled encounters that you have pre-registered and dividing it by the total scheduled encounters available to pre-register. And in the hospital outpatient setting, I can tell you there's a lot of opportunity. Most of the organizations we work with are below 80% in this area. So this is really the apex, the leading edge of opportunity for many patient access departments at hospitals across the nation is getting this robust pre-registration function so you can accomplish so much in terms of risk mitigation and price estimation. So again, just to round out the benchmarks here from NAHAM, good, better, best, 80 for good, 90% for better, and 95% for best. And finally, on our last metric, next slide, please, is our point of service collections as a percent of patient cash. Many of you may be familiar with measuring point of service collections as a percent of net patient service revenue, which is definitely a nice global metric to keep an eye on. But we find that taking a look at your point of service collections as a percent of patient cash is a better measure, a more specific measure for understanding what percentage of all those patient dollars are actually collected at the point of service. It is measuring, how effective point of service collections are going, quite simply. It's calculated by taking all point of service collections and dividing it by total patient cash. And benchmarks to your right, 30% for good, 40% for better, and 50% for best. Many of the organizations that we're working with are really under 10% here. I couldn't emphasize a bigger opportunity for patient access operations than point of service collections. And I think we've had some factors in the last year, with the pandemic, which certainly explain a lot of the downward trend in this area. But in normal times and hopefully soon, right? That this is something that we can focus on as organizations and introduce again as an expectation of our patient population. Okay, next slide. Getting close to the end here, we're just going to quickly go over a couple dashboards and round out a wrap-up slide. So let's talk about a sample patient access denial dashboard. So a few key features of a patient access denial dashboard are that you establish patient access related denial categories. So on the left-hand side of this dashboard, you see in this sample dashboard, we're looking at patient access denials. This is total dollars trended monthly, both for the inpatient and outpatient setting. This organization went with 3 denial categories related to patient access. One is authorization, the second is eligibility, and the third is registration. And so by establishing those denial categories, patient access leaders can interpret how their performance has been. And since this is more of a lagging indicator, it's something that you want to keep a pulse on and make sure that we're integrating solutions to our front end process to avoid authorization denials, avoid eligibility denials, and of course, avoid registration denials. So really emphasize having patient access leaders be comfortable with denials and understanding which ones they influence the most. Second, you want to trend patient access related denials month over month. And that's, again, what you're seeing here in the dashboard. And then finally, you want to set baselines and establish goals. So this is really good when you're introducing tests of change or you're introducing a process improvement initiative in this space. By setting a baseline, you're able to kind of measure how you're performing to baseline. See a lot of organizations take, like this dashboard shows in the second column, a column where it's showing the current month from baseline and showing your performance there. And that's also on a rolling 3-month average there in the first column. And that helps smooth out, right, for any kind of spikes or outliers. So I really am a big fan of the rolling 3-month average and then taking the difference of that from baseline to kind of get an idea of the kind of direction that we're trending in with our patient access denials. Next slide. This last dashboard we're going to take a look at. So this is the key features of a point of service collections dashboard. Really reduce this down to a very small subsection. Usually these are much larger. And in the far left-hand column there, you'd see every visit location in your hospital there. But wanted to take a subset and, again, point 1 here is just establish them by location. I mentioned earlier, in order to drive performance, in order to praise performance, you got to know where these collections are being attributed. So, having line of sight through a point of service collections dashboard, such as this one, can let you know that, how the emergency room is doing in, October of 2019 and November of 2019 and so on and so forth. Your second item here, trend point of service collections month over month. Again, that's just, standard trending for any dashboard to get sort of that longitudinal look at your performance over time. And then finally, display the point of service collections by staff to target education efforts. Now, this is tricky. I mean, I've seen organizations perform this potentially with a blinded scorecard where names are covered, but we're able to see, how are our colleagues performing, kind of gamifying point of service collections a bit, making it a game, and helping encourage performance that way. So we see that be effective. Main thing here is just transparency, open communication, and re-education. And our last slide is next, I believe. Yes, wrap up. So for organizations out there that have listened to this presentation and are thinking about engaging in their own patient access transformation, here's just a quick wrap up of some things that you're going to want to consider and things that we see are really key ingredients of successful transformation efforts. So, of course, many leaders on the call, we want to secure buy-in support from the top down of the organization. That messaging and signaling is important. We find that our staff get on board, right, for any initiative or project, so long as we present it and provide the context. But we're thinking about our providers here. Patient access is in the operational environment. We're in the delivery of care. We are front end. And so as a result, want to make sure that administratively, we are signaling to our providers sort of our expectations for financial clearance so that we can all be good stewards of the financial health of our organizations. And this really speaks to item 2, investing in education to align processes and create a culture of financial clearance. Culture of financial clearance is where, some elements, or one way to characterize it is, everywhere where we encounter patients across our system, we are having a pause. We're having an internal conversation with ourselves about how is this patient financially cleared for this service. And we want to do that in the name of patient satisfaction, because we want to make sure we assign their benefits if they're insured. We want to make sure we connect them to financial assistance if they need it and qualify for it. All of those things. We just want to be thinking through methodically and not just kind of going through the motions, because this really matters. Ultimately, if we can't get this done, we do not get paid. Item 3, you want to define metrics for success, capture data for monitoring, and make performance results highly visible. So again, just to emphasize here, kind of like with the point of service collections dashboard or the KPIs we reviewed, insurance verification, pre-registration rate, point of service collections, get that visible, make sure that that's on a cadence, have all leaders looking at it. For those at the staff level who may not be on those listservs or receive those reports or maybe focused on operational items, make sure that we're directing or we're communicating to our directors and managers that they need to take that on in their huddles, in their one-on-ones, and make sure that we're reinforcing that education. And then finally, let's reward and celebrate employees for high performance. This is a place where we're in front of the patient, we're on stage, and in order to be successful here, we got to have high-performing patient access staff. We're going to be asking a lot of them as we move into this new world of price transparency and other expectations that are going to impact the consumer experience in the coming months and years. So be prepared, and let's make sure that we're investing in those patient access professionals. And like I said, rewarding them for being a good team player. And thank you very much. I think the next slide is just a Q&A template. If there's any questions at all, I'm happy to answer. There's my contact information as well for those that would like to reach out offline and talk. There you are, ascene@bkd.com. Thanks for your time, everybody. But any questions?
Thank you so much, Adam. While we're waiting for questions to come in, just a reminder, you can either chat those in or feel free to unmute on the bottom ribbon. If you called in by phone, you'll need to press *6 to unmute your line. But while we're waiting for those to come in, just a reminder that the slides and webinar recording from all 4 of these sessions will be available online soon. Caleb will be emailing those out to your teams by the end of next week. Please feel free to share those out with any staff who you feel could benefit from the sessions but weren't able to join live. And while we're waiting for those questions, Caleb, if you wouldn't mind pulling up the post poll. All right, thanks everyone for participating in the poll. Well, Adam, I want to thank you for your time today. I don't see any questions coming in, but As Adam indicated, he provided his email address. Otherwise, we are still offering those one-on-one coaching calls, so please don't hesitate to reach out to me if you'd like to schedule a call and have your specific questions addressed by BKD. Otherwise, thank you everyone for participating in the boot camp and have a great afternoon.